morning, and thank you for inviting me. What's basically my homeland. Okay, so I'm here as a representative of Valve Council. I just bring your attention, apart from Stroke Council, which is excellent subspecialty division of ESC, we have a Valve Council. Only recently was established as a council, so you're welcome to follow our activities as well. I'm interventional cardiologist, and I'm involved in about 400 TAVIs a year, which defines my talk today. And it's about prevention or avoidance or reduction of stroke during cardiac intervention. As you've seen earlier in Dr. Lansky's talk, any debris, anything goes during any cardiac procedure, because we are manipulating catheters, sometimes quite hostile environment. There's a lot of atheroma, calcium everywhere, be it angiography or any other intervention. Obviously TAVI, which is now a very common procedure, is something which is a bigger device in the patients who are by definition high risk. You know, stroke, even if it's rare, is devastating in such cases. Vast majority or significant proportion happens during procedure, or they're often silent. And if you look hard enough, you can see some hits on MRI or scan almost in all patients. And also, you know, even if we don't see any clear stroke from bypass operation and open heart surgery, there might be some cognitive decline, even you don't see any definite clinical stroke. And also TAVI matured, because it started 15 years ago. Those inoperable high-risk patients, we're talking about procedure or risk of procedure or non-procedure, 20% Euroscore, so 20% risk of mortality essentially. But we are moving on, and we are coming to other valves, to lower risk group, less than severe aortic stenosis, asymptomatic aortic stenosis. Here are examples of trials which are currently starting or started. So all comers for Medtronic valve. There's also early TAVI when you start doing trials in patients before they develop symptoms in severe aortic stenosis. Again, younger, lower risk patients. Same is for patients who are less than severe aortic stenosis. So this is expanding indication, and it again brings to attention need to eliminate any possible devastating risks like stroke as much as possible. Again, this is just brief overview of those upcoming trials. And we also know that stroke, when we are discussing risk, we're still quoting 2-3% risk of mortality for TAVI. Many patients, they are more interested in quality of life. So as you can see, staying alive, sometimes not the main thing when there are symptoms. They just want a good quality of life, the ability to do activities and reduce symptoms. So really, avoidance of stroke matters. We've got some practical clinical question whether embolic stroke is very relevant problem, and what is correlation of those silent events and how we can improve if you have any gadgetry, namely protection devices. There's a lot of manipulation. There are big catheters. There are catheters, at least 2 catheters go to the heart, to the left side of the heart, then the right side of the heart. And we are monitoring, manipulating stiff wires, placing balloons, expanding balloons, dilating big metabolic instruments, and are giving anticoagulation, obviously, and the patient can have hemodynamics is changing with hypotension. So there's a lot of potential having a stroke. It's could be said frightening that really, if you look clearly enough, MRI, other, we see those hits almost in every case. Same time though, clinical stroke by all definition, and mostly observed by cardiologists or neurologists as a secondary assessor, it's about 5%, even those original trials, 7%. These are original randomized trials for high-risk and inoperable patient. So it's not negligible, but one could say if you're manipulating such a big thing in such a high-risk patient, could be even more here again. This is a partner 2A. The new trials, a slight reduction, about 4%, similar core valve, which is self-expanding valve. So all across all those valves, while strokes are in single digit coming lower, they still exist. And again, here you see even the newest devices. We seem to be performing consistently better than open heart surgery. Nevertheless, we are still talking 2, 3, 4% risk in our patient, not small thing. This is reflected in registries. If you go outside everyday practice, this is some French registry. Again, you see that when stroke happens, which is self-reported, and in this range there are 4%, 55% are major, and most of them happens during early days. As valves are getting smaller, we started with 25 French, now we are at 14 French, almost half size. Perhaps those designs are better and less risky at manipulating small device in vasculature, and we also learn how to use them. Same time, we now have a repositionability option, so more operators can manipulate more, so it might offset the miniaturization. As you can see, it oscillates the risk from published trials in that range up to 5, 6, 7%. Timing of stroke, again, if we talk purely clinical stroke is early after procedure, which is very logical when we manipulate with the debris, and is fallout later, not less, which is again reflected in routine practice in the registries. Same for first or second generation. These are all various TAVI prostheses as they develop over the years. And again, you compare first and second generation, maybe there's some tendency with less, nevertheless still significant, 5% plus. It's not a small number, 2.5 is some early 30 days definition. And learning curve doesn't apply up to some extent. Learning curve is more how to place valve correctly, maybe faster, but not necessarily as an avoidance of stroke. As you see, there's a flattening after early cases and remains so, which is reflected in European as well as in US studies. Again, so it is only limit how you can limit with your skill. Same time, if patient strokes, the risk of dying in general is bad news and is up to 3 to 9 times higher mortality. Patients suffer stroke in time relation with TAVI procedure. So not good news. Dr. Lansky earlier shown you also, as we are now learning about a stroke, how to define them. And if we define them by imaging, we can have strokes in very high percentage, while clinical could be quite slow. So we need to very clear the physician about that. And hence, again, I'll skip this slide to show you that we have a good neurovarg definition, which is prospectively used. How we can prevent it? We are using those prevention devices, SENTINEL, Keystone, Umbrella. So some of them are C marks, and no, they are capturing or removing debris or deflecting debris downstream. As you can see here, the different sizes through femoral artery, brachial artery, radial artery, or carotid artery, and they cover either all circulation or on left side, brachiocephalic, left common carotid, or trigard, can left subclavian as well. Here, example of such a devices. It's very logical. Obviously, those devices themselves require manipulation in the body, which itself could be risk of stroke. So we really need to know more. Again, there are some examples, claret. And where are we? So there's a lot of potentially promising data from single observational studies. Clean TAVI, claret, there was a reduction of those hits. This is clean TAVI study. This is impressive single study from Ulm. And this is TriGuard pool analysis. But when it is subjected to randomized trial, and currently is only one randomized study called SENTINEL, which was looking into Endpoint, which involves stroke. It was a training, how to manipulate device, used to device, and using and not using, and it unfortunately failed. So despite the reduction of MRI lesion, it failed to reach primary endpoint in direction of stroke. It seems to be, though, it's safe, but doesn't make any difference in clinical rates. Here you see it again, and again you see what kind of debris. You can see part of a valve, foreign material, necrotic or everything, but that reduction was not significant. Same time, at least at this stage, we can say the devices are safe. They didn't contribute any renal failure, anything else that could be related to higher amount of contrast. So, and didn't increase mortality for sure, but so they are not superior. They seem to be safe. And again, as Dr. Lansky showed, we just need to look further days beyond. While we think it all happens procedure first 24 hours, we probably need to expand that interval for monitoring afterwards. Again, this is just a confirmation it's safe. You don't see any more disabling problems with the kidney usage of that. So, where you can use it today? Maybe even without evidence, sometimes you feel as an internist you should use it when you see some mobile structures on aortic valve, when you see thrombus in left ventricle, patient no option, you have to do it. We've got a lot of atheroma in aorta, maybe in presence of atrial appendage. That would be what I would propose as a pragmatic approach in absence of evidence. On the other side, and again, Alexandra left us, enthusiasts that would say the seatbelt equivalent, so you need to give it to everyone because you don't take a chance because you can see a lot of horrible things coming out of there. Why this is impressive? We just need clinical evidence, which we don't have at the moment. So I can conclude that stroke continues to be a clinically relevant problem in TAVI procedures. Silent infarctions are frequent and looks like they have an impact on cognitive function. While initial results with protection devices are promising, so far it failed in validating in powered randomized trials. But as we are moving to low-risk groups and all comers in TAVI, we should aim for no new brain lesion as a gold standard after TAVI. Thank you very much.